The steps that you're doing on the Dentoform simulate what you would do to a patient to mount a case for diagnosis and treatment planning. When we have mounted diagnostic casts, we can have the following. We can supplement our examination. This type of thing helps us to diagnose things like malposed teeth, low-hanging tuberosities that interfere with occlusion on the opposing arch, interarch distance problems when there's not enough room to even place teeth, and even helps us to see some restorations that need to be replaced. It also permits a detailed analysis of the occlusion. Just think about it. If we could remove the lips, the cheeks, and look at the patient's teeth from the tongue side, how much more helpful that is than just being able to look into the oral cavity as we have to do with all of those things present. It also helps us to have something for patient education. When you get ready for treatment planning, it can be a tremendous asset where the patient actually understands what exists in his oral cavity and the problems that he has and what you're trying to do and correct by your treatment. The other thing, it's a great record of what existed prior to your treatment, and if you're doing some major reconstruction, it's very necessary that you keep these diagnostic casts in case a conflict occurs and even something so severe as litigation. You have evidence of what you had when you start. The patient may or may not require an occlusal equilibration. If you have a defined maximum intercuspal position and enough teeth that there is no doubt where the patient closes to function, then you may use maximum intercuspal position. If the patient does not have many teeth that intercuspate well, and the patient wanders from one position to the other when you ask them to bite down, then you would possibly consider centric relation position and do an occlusal adjustment to make maximum intercuspal position and centric relation the same. This patient has enough of a repeatable bite that we will restore him with his RPD in maximum intercuspal position. You may not know some of this until you actually finish mounting the case. Before you start any permanent crowns or restorations, you would want to make sure that your equilibration of the patient is completed at that time. Whatever you do, you want to make your diagnostic impressions at the first appointment with the patient. If you do not finish your various exams, you can finish them at a subsequent appointment. If you have to use record bases and occlusion rims to mount the case, making the impressions at the first appointment allows you to have some diagnostic casts between appointments to make record bases for the second appointment. At the second appointment, you can finish your exams and then adjust the occlusion rims and take records of your patient so that you can mount the case and prepare for treatment planning at the third appointment. If you do not make diagnostic impressions until the second appointment, your treatment planning will be stretched out until the fourth appointment. So this is one of the ways that you can save time and valuable appointments for yourself. For the absolute best results, pour your cast using vacuum spat mixer to mix your gypsum product. We will use Whip Mix Yellow Quickstone for pouring our diagnostic impressions. Trim the diagnostic cast on the model trimmer, leaving about a 1/4 inch land area around the periphery. Also make sure that it is a 1/2 to 3/4 of an inch thick at its thinnest point. Be sure you don't trim off critical anatomy. You want to have the retromolar pad complete, the tuberosities complete with the hemular notch, and the retromylohyoid fossa should appear on the cast. So be very careful not to trim off the important anatomy. In the past, we used the indexing methods shown in the upper 3 pictures on this particular slide. We are moving to the one shown on the bottom left because we feel like it's a little more accurate. In the past, the 3 indexes on the corners, some of these were broken off when the cast was separated and it was more difficult to reorient the cast on the mounting plate. So use the one shown in the bottom left. When making the index in the cast, You may use a lathe burr that has somewhat of a rounded shape. The indices should be cut perpendicular to one another and extend from one edge of the cast to the other edge. This way, when the lab technician gets the case, he will be able to see that it is indeed present. They should be cut in the form of a half circle, approximately 3 to 4 millimeters deep. This is just a reminder that you should put some type of an identification on the posterior surface of your cast if it's laying around the laboratory. I usually will place a piece of tissue paper with my name on it even after I pour the cast and stick it into the stone so that it doesn't get moved around and I don't recognize my own cast. If you place it on the undersurface of the cast, remember though that when you go to mount it, it's going to be obliterated and hidden once the case is mounted. Why do we mount diagnostic casts with record bases? First of all, whenever you have two casts that are not steady when you hold them together, they would wobble if you were trying to mount them. If they can be moved slightly anterior or posterior and you don't know which position is the one that is really on your patient, or if you know that the weight of the mounting stone alone is possibly going to cause movement in the cast and distort your occlusion, the best way to mount is with occlusion rims. Here is a clinical patient who you can see from the two casts that they don't have a chance of being put together and they will sit stably while you mount the case. This one definitely demands occlusion rims to mount the set of diagnostic casts. This is another example where there is no way to hand articulate these casts in order to do a proper, accurate mount. The articulator must duplicate the patient's occlusion in order for you to make a proper diagnosis and a treatment plan. This one too demands record bases be used to accurately mount the case. I saw this case at a local laboratory when I went to visit my lab man. They were submitted by a local dentist to the laboratory requesting on the prescription a final complete set of dentures be processed for this patient. Which of the two lower pictures is the correct position for this set of cast? You don't know. What do you think of the chances of success are for this patient to have a complete denture with any kind of occlusion that's accurate on it? There is no special formula for the design for the base part of the occlusion rim. Designed for stability, record bases should not be able to move anterior posteriorly or from left to right. They should be very stable on the cast. They should go into all the embrasures for stability and prevention of movement. What does this mounted case tell you? It tells you that we have a problem on this patient's left side. There is absolutely no room for teeth to be set here. The lower posterior teeth have extruded into the existing space above. There is also restrictive space in the anterior of this case. Some major dentistry that is very costly will be indicated if these areas are to be fixed, and the patient will now be able to see why you have treatment planned such things as crown lengthening, possible endodontics, and crowns on certain teeth. You would also want to present options to the patient, which may include extractions of some of these teeth. The articulator settings for our project will be that the incisal guide pin will be set at the 0 point before you mount the case. And we will use this point because the teeth are going to be brought together until they touch, and we will record the bite at that touching position. The incisal guide table will also be set at 10 degrees as far as an anterior-posterior setting. Set the lateral wings to 10 degrees and the Bennett side shift at 15 degrees. A study was done of many individuals, and it was determined that 15 degrees was the average setting during this study. Set the condylar inclinations at 30 degrees. If you had a live patient, This condylar setting would be determined by doing a protrusive record on the patient, much like the one that you did of your fellow student in the TMD course. A Facebow record is made of the patient usually to mount the upper cast. The Facebow orients the maxillary cast on the articulator in the same relationship to the condylar elements of the articulator as that of the maxilla is related to the rotational point of the condyles. The arc of rotation is thus the same for the patient on the articulator and for the patient himself. This is important when you have a case where anatomical teeth are going to be used on your prosthetic case, or when crown and bridge is being done, or full mouth reconstruction. The Facebow registration orients the maxillary cast on the articulator to duplicate the rotational point on the articulator to the same relationship as that you had on the skull. The external auditory meatus is used to insert the Facebow, and it is approximately 11 millimeters posterior to the condyle point of rotation on the human. The place on the articulator where you place your Facebow apparatus is 11 millimeters posterior to the rotation point of the articulator. This rotational arc is important when you're doing full mouth or full anatomical occlusion. It's important for adjusting the occlusion on the distal and mesial inclines of the cusp. The third point of reference on the patient's face is recommended to orient the maxilla on the articulator. Different articulators and Facebow apparati recommend different anterior reference points. You're familiar with two of them. The Hanau Articulator and the Springbow uses the infraorbital notch as the third point of reference. The Whitmix Articulator's Facebow apparatus uses the nasion as the third point of reference. The infraorbital notch in the external auditory meatus will parallel something called the Frankfurt horizontal plane. It was decided that a plane passing through the inferior margin of the left orbit, the point called the left orbitale, and the upper margin of each ear canal called the external auditory meatus, and the point being called the porion, was close to the position the head is normally carried in a living person. Since we do not have a way of taking a Facebow on our mannequin, we are going to mount the maxillary cast on the Whitmix articulator using a jig obtained from the dispensary. Place the jig on the articulator. Place the mounting plate on the maxillary member of the articulator. Place your maxillary cast into the jig and close the articulator and check to see if there is room between the cast and the mounting plate. If there is not, check to see first if your pin is set at 0 point. If there is not adequate room yet, you may have to adjust the base height on your diagnostic cast and re-index it. Apply Vaseline, a lubricant, to the cast indices. This will allow the laboratory to remove the cast from the articulator and place it back into the exact same position as when they received it. Mount the maxillary cast using lab plaster or stone. Occlusion rims are used to help mount the case when they cannot be hand articulated. Here's an example of the ones that have been constructed for the Dentoform case, and the one on the right is the one that was constructed to our patient that had critical teeth missing to stabilize the occlusion. When you get your record bases back today, you need to make some analyses. If your record bases fit and are stable on the cast and not on the Dentoform, analyze the following. What have you done? Did you adjust or scrape on your cast in any area that could have created a negative on your cast? If so, you may have a positive on your record base that cannot or can be adjusted to make it stable on both the cast and on the Dentoform. Did your alginate pull loose from your impression tray when removing it from the Dentoform? Your ridges then will be in a different position on the cast than on the Dentoform. Your record base would fit the cast, but would wobble severely on the Dentoform. You would have to remake the impression and remake the record bases to get this one to work. If your record bases are not stable on the cast or on the Dentoform, you need to think about the following. First of all, you must make the record base an occlusion rim again, as there's no way that you can make it stable on the Dentoform if it never fit the cast either. And you certainly can't make the record base on the Dentoform or on your patient. The above problem has no guarantees that remaking your record base will make it fit on the Dentoform. If your impression and cast were inaccurate, you will remake the record bases on your cast, and there's still a possibility that it may not be stable on your Dentoform. This is an example of how the rims can be reduced to allow a 2 to 3 millimeter space on the Dentoform for compound. We're going to use whatever compound that will be either gray stick or green stick compound. Note that that first premolar on the bottom left picture, you need to have enough clearance right there, at least a couple of millimeters between the occlusion rim and that cusp tip of that first premolar. When you try your rims onto the Dentoform, you will find that the teeth are propped open. They cannot come together. You're going to have to adjust the rims until the teeth can all come together and you see about a 3 millimeter space between the teeth and the occlusion rims, leaving room for recording medium. We're going to use gray stick compound or green stick compound to record the jaw registration. This picture shows a complete denture patient against a removable partial denture on the lower. The occlusion rims are adjusted to the proper vertical dimension of occlusion, and then the posterior rim is further reduced to create space on the posterior area of the mandible for compound to be placed between these two rims to record a jaw registration. We prepare the rims for the record by placing non-parallel V-shaped grooves across the rim on the maxillary arch, as shown in the picture on the left. The grooves are sometimes placed on the lower rim also, so that if the record slips off for some reason, you can place it back onto the rim using the record indexes. These record rims are very questionable in these pictures. When the patient bites down on the rims during adjustment in the mouth, they may slip off the crest of the ridge very easily because there's no support by the wax down the sides of the record base. The problem with having record indexes that have two parallel of walls, as shown on the picture on the left, instead of more V-shaped walls, is that the walls of one index may actually be undercut to the walls of another index. The result then would be that the indexes get locked together and it will rip off your rims when you try to have the patient separate or open his mouth. The point of this slide is to show that if you make your indices like an equilateral triangle, as shown on the images to the left, you will not run into a problem if your two indices are not perfectly aligned parallel to each other. If the walls are too narrow and you use indices more U-shaped, like on the right, with very parallel walls, you may break them off, or they may pull your wax rim off the base plate when asking the patient to open his mouth after the registration is made, because the walls are actually undercut to one another. Also, you have to remember that the articulator and the mandible close on an arc. If your ridges are very parallel, when you
open and close, you're going to run into an interference. And when you check the occlusion record, the patient may hit a bump before totally closing into the record, which immediately makes him change his jaw position to avoid the interference. This is a natural response of the patient, but your jaw registration will be off.
After you have adjusted the rims and have cut non-parallel index screws into the wax, place a separating medium, in this case it's Vaseline, on the wax opposite to the arch where you're going to have the recording medium. This will prevent the hot compound from sticking to the wax rim while taking a record.
Next, you're going to heat the compound using a Bunsen burner or a Hanau torch. Apply it to the mandibular occlusion rim. Temper the hot compound in a controlled 140-degree water bath before taking the rim to the mouth. You need to control the temperature as it is possible to burn the mucosa severely.
Place the recording medium, in this case gray stick compound, in the patient's mouth to record the occlusion. Hold the rims down while you are recording this bite registration. If rims oppose rims, then the indexes should be placed on the wax on the opposite of the one in which you place the compound. I like at this time to try and take a wet finger or one with a little Vaseline, put it in the patient's mouth and rub it across the side while it's still warm in order to get a nice smooth adaptation of my compound to my record base. The patient in this picture is a complete denture patient on top with a removable partial denture on the lower. The record bases on an RPD case are often made on the framework after it's been returned so that the lower rims can be held in place with direct retainers while making a jaw registration record. This makes it easier. This, of course, cannot be done if you have to have record bases in order to mount a case prior to having that framework made. It would be done with conventional record bases. The record, after it's made, is trimmed flush with the wax so that it may be easily read when it's checked in the mouth. You want to trim the compound to show only the cusp tips. You are therefore trimming any really deep guiding planes away from the material. If the teeth are really deeply embedded in the wax, then when you go to check to see if you have the right bite, there's almost no way you can go wrong because all of those sidewalls guide you down into position and make your bite look very repeatable.
When you trim the records in this manner, you achieve a couple of things. One, the records can be easily checked in the mouth for accuracy because you have complete visibility of the record. You can see if the left side and the right side are touching at exactly the same time and whether the anterior and posterior are touching at the same time. The cast can also be placed together for an accurate mounting with no evident springy action. This is extremely important when you're using polyvinyl siloxane. If that material wraps all around the teeth, one, you can't even see, but two, you get this springing action and your mounting is off. Use metal rods made from cut metal coat hangers, wooden sticks taken from the cotton-tipped applicators, or strips of the tongue blade, and secure the two casts with compound or sticky wax before you add plaster to mount the lower cast. The casts are placed in position using the record bases, and they're secured into position by those metal rods, cotton-tipped applicators, or tongue blade strips before adding the plaster. You now add the plaster, and this one in particular shows that the student tried to add all of the plaster at once rather than adding a small amount and then going back and finishing the cast mounting. This is much more difficult to clean up and takes far more time than if you add a little bit to get the cast secured to the articulator and then go back and finish it up after the fact. We use the cross form of indexing the cast as shown on the bottom left because the laboratory can tell whether the case is indexed when it arrives at the lab. The cross method goes out to the sides so it's visible when the case is mounted. The lab has to remove the cast from the articulator to work on the case. They then replace it onto the articulator when they're finished. These indices make it possible for the cast to be oriented in the exact same position on the articulator. If they receive a case, like the one on the upper left, with improperly indexed cast, they are instructed to return them to the student for proper mounting.
Record bases can be constructed from several different materials. You can have them constructed out of triad material. This happens to be acrylic resin where you mix a liquid and a powder together. They can be made out of some thermoplastic materials where you get sheets and then you put them in hot water. They will become very mobile or movable. You can form it, and then as it cools, it sets and becomes hard. You can have them constructed out of metal by your laboratory, which would be very expensive, but these are just a few of the options of what they can be made out of. As far as those grooves that are placed into the ridges as indexes, you don't want them to be too sort of like U-shaped or real straight walled, because one, they can be undercut to one another and rip off the wax during the time. They should be more like an equilateral triangle that's about 2 to 3 millimeters in depth. You don't want them to be too narrow, or again, wax will get caught down in them and maybe rip off the occlusion rim, and you have to start back at square one. Well, here we have a little bit of artistic talent coming out. This record base is really cute, but it's not very effective. You have a poor rim that doesn't have any support on the buccal or lingual surfaces of the record base. When this patient bites down on that rim may go flying either to the buccal or to the lingual without those supports from the rest of the record base. Here we have our patient sitting in the chair on whom we are going to construct a partial denture. First appointment, we're going to gather all of our information and do all of our exams, as well as making impressions for diagnostic casts. We take diagnostic impressions of the patient at the first appointment. Go back to the lab after your appointment and pour your diagnostic cast. Between appointment 1 and 2, make your record bases and occlusion rims for the patient. Here are some record bases that are made on a very unusual patient who has a complete scissors bite. We were able to get a registration on this patient, but it's a very unusual one. The teeth on these two casts individually, without them being mounted, may look perfectly good. But if you mount these two casts, you can make a proper diagnosis, and we've got some real complicating situations here. The molars on the patient's left side are all extruded due to wear and lack of an opponent. You really cannot restore anything on this patient in the way of removable partial denture without some major extractions. When the record medium is being used to record the soft tissue in the mouth, you cannot predict that the cast will have the soft tissue in exactly the same position as in the mouth. Making an impression usually depresses the soft tissue, and the cast will reflect this difference in the tissue positioning. When you place a record made in the mouth onto the two casts, it's hard to tell what you're going to get, so that makes a very inaccurate record for mounting cases.
When you're using PVS as a record, polyvinyl siloxane, you want to record only the occlusal cusp tips, as is shown on the lower picture on the left. If more than that is recorded, the record should be trimmed back to show only those cusp tips. If soft tissue is involved, you will have an inaccurate mounting. This is often a question that's given on the boards. If you make occlusion rims on one set of cast, can they be used on another set of cast, and why? Well, the answer is that the cast was made and the soft tissue on one cast is never the same as the soft tissue on another cast. So when you made your occlusion rims, they will seat very accurately on the cast on which they were made. But if you then try to transfer them to the other set of cast, because of the differences in soft tissue, those records will not go down in place, those base plates. And therefore, if you took a record on them and you tried to mount with them, it would be extremely inaccurate. Here is a properly done set of occlusion rims after they have been placed back on the articulator and adjusted. Notice the V-shaped grooves that are a little bit wide open. They're probably about 3 millimeters in depth. Note how the compound comes right out to the edge of the occlusion rim and goes really deep into those V-shaped grooves. And notice on the lower one, and it's probably not as perfect as it should be on that first premolar, but you would like to see the incisal edge to be confluent with the compound that's on the lower arch. It would look more similar to what you see on that upper part of the rim where the V's are located, that they would come together more accurately like that. The opposite side has an equally nice arrangement. Buccal cusp tips of those maxillary teeth go right into those grooves on the mandibular, and you would see a real nice smooth transition between the compound and the tooth. This is the way it should look when it's turned in. If you try to redo one side, you're not going to achieve much. If you make a mistake and you want to do it again, then you must heat up both sides at the same time in order to get an accurate result. This slide's being included because it shows a case that was just returned from the lab for a student case in the clinic, and it displays some of the ways to replace teeth in the arch that we've been talking about. On the left picture on tooth number 5, 12, and 13, you see facings have been used. Note that the occlusal surface is in metal and the buccal surfaces are white. On tooth number 3 and 15, a tube tooth has been the choice of replacement. Note that those occlusal and buccal surfaces are white. Therefore, you can determine that the tube tooth is the more aesthetic choice of the two restorations. In the picture on the right, you see examples of a metal tooth replacement on number 18 and 30, and tube teeth on numbers 19 and 21. If number 30 and number 3 oppose one another, you will see more rapid wear on tooth number 3 because of the dissimilar materials used opposing one another. The tooth with the most resistance to wear will break down the weaker one, and the resin tooth will show wear faster. A facing could have been used on number 3, and then the metal would oppose metal, and the case would retain occlusal contact longer in this area. Here is a side view of the different teeth. Now I'm not really happy with teeth number 12 and 13. Look at their occlusal length compared to 11 and 14. They're too short. One of the reasons to use a facing is that the buccal occlusal surface can be left long because it has a metal backing behind the buccal cusp if the deep bite exists. The tube tooth, if left long, would have a very long, thin buccal cusp that would be unsupported and break more easily than the facing. so I wanted the teeth to be as long as the teeth in front and back of the edentulous space and be protected from breaking by the metal surface supporting the buccal cusp. They didn't send it back that way. Here's what the case looks like in the patient's mouth. Notice what I was talking about when I mentioned the length of the teeth. I think the right side of the patient is much more acceptable than the left side. Do you see what effect the properly constructed facings does compared to the ones that were on the left side where they were left short, and how it has an effect on the aesthetics of this case? Finally, here are the occlusal views of these partials in the mouth. What do you think? You guys have a great day, and I hope everything goes well for your upcoming exam.